So, hello everyone, and thanks for joining us for today's seminar's webinar series. I am Karin Gemini, a research fellow from the University of Wuerzburg in Germany. As you all know, the goal of the SONA seminars is to bring experts in neuroscience from all over the world and students and university staff, especially in Africa, together. And this provides a great learning exchange platform and helps to make neuroscience accessible to all. At the same time, this is also a great opportunity to get guidance and mentorship from those experts. Today, it is my very great pleasure to welcome Dr. Michel Bieber as a speaker in this series. Really, I just want to give a brief introduction about Dr. Bieber. So Michael is currently a research fellow in the neuroscience department of neurology at the University Hospital of Wuerzburg in Germany. Michel has obtained his master's degree from the University of Wuerzburg in Germany, where he studied biology. He then started in plant research, where he studied the influence of lipid transfer proteins on the plant pathogen resistance against bacteria and fungi during his PhD. He was awarded his PhD from the University of Wuerzburg, and then he moved to the stroke research field in neurology at the neurology department of the University Hospital of Wuerzburg. And one interesting and very cited piece of work illustrated that a focal cerebral ischemia in mice can lead to the development of chronic systolic dysfunction of the heart by increasing systemic activity. So he's currently investigating highly transferable strategies of ultra-early stroke treatment by blocking, for example, detrimental immune cells and platelet responses following an ischemic insult. His work has been published in prestigious journals like Analog Neurology, Stroke, who are very specialist journals in the stroke field. And Michel Bieber is also a teacher, a mentor within the department. He is one of those rising stars in stroke research in Europe, and his scientific achievement has been crowned by several awards. Very recently, he received the Henschel Prize for Stroke Treatment. That was in 2018, and it's a very prestigious prize that is given only to two young scientists a year for an outstanding publication on stroke. So I could go on and on and on about Michel, and I'm very fortunate to have Michel as a colleague also in the department. But I have to stop here. I'm very excited about this talk. We're really looking forward to hearing Michel today. But before we start, I would like to remind everybody that this webinar is designed to be interactive. So you can ask as many questions as you would like by writing in the chat section that you will see on your screen. And Michel will have to answer the question during the Q&A session following his presentation. Well, thank you again, Michel, for taking your time to share your research with us today. And I will leave you on the stage.
Yeah, thank you, Karin, for the really kind introduction. And I think, I will start also now with my presentation. So, which has the title Insights in Ischemic Stroke Research. I changed it a little bit, but I divided it also in two parts. So, first of all, I will tell you something about thrombo-inflammation in the acute stroke in mice. And in a second short part, I will tell you something about the heart and the brain connection. So this is, in our case, the Ziegfeld study. First of all, I will give you a quick rundown on stroke, because the therapy of stroke is really time dependent, then because you lose 2 million neurons per minute, so the slogan "time is brain" really matters in this relationship. I think, as most of all of you maybe know, stroke is the second leading cause of death and disability worldwide, so it's a big problem in the whole world. So when you want to have a number, in Germany, we have around about 270,000 stroke patients each year, which are divided into 80% which have an ischemic stroke and 20% with neural bleeding, so they have an hemorrhagic stroke. And for the ischemic stroke patients, there are until now only 2 therapeutic options available. It's the IV lysis with RTPA and the mechanical thrombectomy. And in acute ischemic stroke, the advent of mechanical thrombectomy dramatically improved outcomes, so for the last years, but a considerable number of patients still do not benefit despite successful recanalization. And this phenomenon that ischemic damage continues despite restored organ perfusion has been denoted as ischemia reperfusion injury. And ischemia reperfusion injury, this is the topic of our research. And so I come to the first part, the thrombo-inflammation in the hyper or in the acute stroke in mice, because commonly referred to as ischemia reperfusion injury in the stroke model of mice. So our used model is the transient middle cerebral artery occlusion model. Thrombo-inflammation has been identified as the driving force of stroke progression despite recanalization. What did this mean? So thrombo-inflammation means there is an interaction between immune cells, platelets, and also the vascular system. And within this interaction, ischemia reperfusion injury is gone in the, or is more or less, how can I say it? Yeah, this interaction is really, has a massive part in this injury. So first of all, I think it's good to have an overlook what model we use. So we'll use a focal cerebral ischemia model by the occlusion of the middle cerebral artery. And when you look at this picture, you have at the left side a mouse brain, and you see here in red, this is a filament. We pull this filament into the artery until we reaches the divided part where the blood supply of the MCA is arrived, and then we stop this blood supply of this red area where the middle cerebral artery is for around about 1 hour normally, sometimes even shorter, but the normal method is occlusion for 60 minutes. And after the 60 minutes, we have a reperfusion phase, which means the filament is gone out, and this area has normal oxygen supply and nutrient supply for a time period of 23 hours. And after that, we sacrifice the mice. You can see it here at the right part. These are brain sections from the mice, stained with TDC. And with this staining, we can see at the white part, this is the infarcted area. So this is a normal control animal infarction in our method here at the right side. And what we normally do, so when you're looking here at the experimental plan, is that we have a transient middle cerebral artery occlusion, which means we have an ischemia for 60 minutes, so stop of supplying blood to this area. And then we have a reperfusion phase, as I told you before, for 23 hours. And normally we have a treatment before or after the occlusion of the MCA. And then 24 hours after this occlusion, we have the tissue sampling. And so the few data I will show you in the next slides are commonly done with this experimental plan. So first of all, as I told you, thrombo-inflammation is an interaction between platelets, so with the vascular system, also with immune cells. And one important factor which we found was that glycoproteins, like here GP1B in green or GP6 at the middle figure in red, these are some important factors. So they're important for platelet adhesion and also activation at the injured vessel wall. And also these two factors play an important role in our model of ischemia reperfusion injury. So previously we could show that when we treat these glycoproteins, you can see here, these are infarct volumes 24 hours after the middle cerebral artery occlusion. And we treat animals with antibodies against GP1B or also GP6 against these two glycoproteins. And within this treatment, we could observe that the animals had were protected against ischemia, so they have lower infarct volumes. This at the left side, the treatment was before the occlusion, so before we did the surgery. But you can also do a therapeutic treatment. That's here shown at the right side, showing here with the treatment of GP1B antibody. Looking here then at the infarct volume, we have also here a reduced infarct volume if we gave the animals the antibody after the surgery. So meaning we have maybe also a therapeutical option besides RTPA and also mechanical thrombectomy. So when we think about clinical situations. Furthermore, when we're looking at the platelet side of thrombo-inflammation, here you see also the Peterson score. That's a functional score. So we have a neurological functional score of the mice looking at their behavior. And yeah, as I can tell you, only from this figure is that also the animals which show lower infarct volumes also showed a better behavioral outcome after this middle cerebral artery occlusion. So this is another glycoprotein. That's glycoprotein 2B and 3A. Before I told nothing about it, but I will want to show you also this data. Why I want to, or why want I do this is that what we observed with this glycoprotein. So we saw that GP1B is protective against ER injury, and also GP6, but GP2B 3A treatment with this antibody against GP2B 3A showed us that first of all there is no reduction in infarct volume, but what is also shown, and this is detrimental, is that we observed heart bleeding complications in this mice. So which means here is also first of all no protection visible, but also we have an impact of this factor on homeostasis. And this is really important in ischemic stroke treatment, because if you have an hemorrhagic stroke and you don't know it, and you gave them some platelet factors or like aspirin, which is one drug you used in the clinic, then it could be that the bleeding is more massive, and then of course the patient could be dead by it. And so this factor is no treatment option in the case. And so we also targeted with GP1B and also GP6 treatment if it's had an impact on homeostasis. And here with MR technology, we observed, what we observed here with MR technology is that the infarct volume in the treatment with RTPA and combination treatment with RTPA and GP1B antibody, we see also a reduced infarct volume, but nevertheless we saw also no bleeding complication, which means GP1B treatment has no impact on homeostasis. And furthermore, the same effect we could also observe with GP6 treatment, which is in our case very important because we have an impact on the thrombotic side or on the thrombotic side of this factor, but not on the hemostasis side. So which is, we have a good treatment option available. This is now the other part from the thrombo-inflammation in ER injury. These are T cells in our case. So it's also some data known from neutrophils or macrophages, but our focus is on the function of T cells. And what we nicely could observe was that in mice, this is the REC1 deficient mice. This means that these mice don't have B cells and also no T cells, that these mice are very well protected against ischemic stroke. Looking here at the infarct volume only. And then we did another experiment, and this was that we have an adoptive transfer of native B cells or native CD3 positive T cells in this mice. And what you observe here then at the right bars is that with the adoptive transfer of B cells, the REC deficient mice are already protected, which means B cells have no effect on the infarct growth. But when you add them some CD3 positive T cells, then the infarct volume is like in wild-type mice, so which means that T cells have a detrimental role in the experimental cerebral ischemia in comparison to B cells, so which means we have a T cell-driven effect in this mice. And then were in our lab also some further analysis of this T cells. So we used an FTY 720, and it's also known as fingolimod. It is a thingosine 1-phosphate receptor modulator, which sequesters lymphocytes in lymph nodes, which means you have no surrounding lymphocytes in the blood. And so what we observed there, when you have a lack of lymphocytes, then also with the FTY 720 treatment, we get reduced infarct volumes also at day 3, not only at day 1 after MCA occlusion, but also on day 3. And also the neuroscores show a better functional outcome at this treatment. So that we have not only a role of platelet factors, then also a role of T cells, and also with the interaction of these T cells and the platelets, and this is now ongoing research of us, shows a thrombo-inflammatory effect in this ER injury model. So that I come also to the first summary of this part. So I can tell you that the targeting of different platelet glycoproteins like GP1B, GP6, but already not GP2B, 3A, protects from ischemic brain damage in our transient MCO model. And also this treatment showed no impact on homeostasis, which is very important for the clinical implication of such antibodies. And we also, or I can also show you that this effect is also T cell driven, because the REC deficient mice lacking T cells were similar protected from this ischemic stroke, and yeah, showed also a really impact on the thrombo-inflammatory side at this ER injury. So that I now come a little bit to an outlook of our further research. So because there is an ongoing debate whether the reperfusion per se is detrimental, or alternatively a common destructive process is maybe set into motion immediately during the ischemia phase, which paradoxically persists upon successful recanalization or reperfusion. And yeah, in our case, we think that maybe thrombo-inflammatory processes during this early period may be operative, and already, we can change it with our antibodies. So maybe this is our future work or further work we're doing now, to look at the really early phase of the ischemia where already the middle cerebral artery is occluded. So here is an outlook for the experimental plan. We have a permanent occlusion then. We let the filament in the artery and want to see if the treatment strategy is already functional at this early time points. And yeah, this is the theme of this first part of my talk. So we have some guys from the neurology, like Professor Stoll and Professor Kleinschnitz as the head of it, and from the neuroradiology and also from the experimental biomedicine in Wuerzburg. So it's a big team to do this research stuff. And so now I come to the second part of my talk, and this is further work from our lab. So the heart and brain connection, the sick phase. So sick phase stands for stroke-induced cardiac failure in mice and men. So it's a long name, but it goes about the connection between the heart and the brain. Because what is known is that cardiac failure is known to be a risk factor for ischemic stroke, but there was the question, can you turn it around? And also ischemic stroke is a key player for cardiac dysfunction development. And when you look at literature, you can find some acute cardiac complications after stroke in men. So there's a higher percentage of myocardial infarction, of cardiac arrhythmias, a stress cardiomyopathy, and also some elevated BNP and troponin T values. But nothing is known about the chronic phase, if there chronically is something, an impact of ischemic stroke on heart failure. And also when you look at mice, you find only acute cardiac complications. Like here, this is an example for a permanent occlusion of the middle cerebral artery. There it is that the left ventricular systolic pressure 24 hours after the surgery is decreased. You see it here at the top of the right bars. And at the upper part is, at the down part, sorry, is that this permanent occlusion leads to construction band necrosis in the heart tissue. But already also here, nothing is known about a chronic, about the chronic phase, and within that, a chronic development of a heart failure after ischemic stroke. And this was the beginning of our research stuff at this area. So what did we do? We had, as I already explained, our ischemia model of the transient middle cerebral artery occlusion. In this case, only for 30 minutes, because the mice did not live only 24 hours. They had to live 8 weeks after the surgery. And what we do was, before the surgery, we had an echocardiography of the heart of this mice, and also then at different time points after it, so day 7, week 3, and week 8. At week 8, we had also some hemodynamic measurements with a catheter, and then also some blood sampling and tissue sampling of the brain and the heart. And then we had also a treatment group, but I will come later to this. So first of all, what I can show you is that at the left side, you see a mice brain. This brain has an infarct 24 hours after it. You can see here some sections of a control animal, a sham animal at the middle, and an TMCO treated animal. For 30 minutes, you can see the white part, so there is an infarct. And at the right side of this slide, you can see some FDG PET imaging, which means FDG, what you can do with FDG measurement is you measure the glucose uptake. And we measured the glucose uptake in the brain of this mice 8 weeks after the surgery. So this is the important point, not 24 hours, so 8 weeks after it. And what we found was, when you look at TMCO treated mice, that there is a part where no, so it's a green area, which means there is no glucose uptake anymore. And this area is where our infarct was. So this is the important stuff about this. And now then I come to some functional stuff of the heart. Don't be confused, because what I only want to show you is that this focal cerebral ischemia, what we have in the brain 8 weeks after the surgery, and that's the important point, leads to a chronic systolic dysfunction. but only in the case when we have a right-sided stroke. If we do the same surgery at the left side of the mice, then we have, this leads not to the chronic systolic dysfunction. So which means, looking here at the ejection fraction of the mice heart and also at the fractional shortening, this is a measurement of the percentage of the blood leaving the heart and each time it contracts. So it means that the contraction of the heart isn't as good in the TMCO treated mice at the right side than in the left side. So we have a side effect of the brain, and when we treated the brain at the right side, we have this effect. When we treat it at the left side, then this effect is gone. So this means that the right side is important for the heart function in our case. And what we then further did was a correlation between the brain lesion and the ejection fraction. So then what we can see here is that with a higher right hemispheric atrophy, we find also that the heart function is worsening. This is the only one, what this figure has told you. And what could be the driving effect? And therefore we looked at the plasma, the blood plasma of this mice 8 weeks after the surgery. And what we found was that plasma norepinephrine, epinephrine, so sympathetic markers, also cortisol, were significant elevated in this mice, in the TMCO treated mice, in comparison to control and sham operated animals, which means that this sympathetic activity, or in our case, we think that this sympathetic activity is the driving force of the chronic systolic dysfunction development. And therefore, we thought, then what could we do? And we thought we could do a pharmacological treatment, looking at the clinic. Patient with a heart failure, normally they get a beta blocker like Metoprolol, and we already did that. So when the mice get Metoprolol, and here you see the comparison of vehicle, which means this is only the TMCO treatment 8 weeks after the surgery, in comparison to Metoprolol treatment, they get it in the drinking water, this mice. We see that the development of the systolic dysfunction is gone. Because, first of all, what you can see here is that the sympathetic markers, norepinephrine, epinephrine, and cortisol in the plasma, the levels are very low in comparison to the vehicle treatment. And further, when we look at the heart function, the heart rate, this is the normal function of a beta blocker, that the heart rate is going down. So it's significant lower than the vehicle treatment in the Metoprolol group. But also the fractional shortening and the ejection fraction, which means it's a marker for the contractility of the heart. They were better in the Metoprolol treatment, and also they were better in the Metoprolol treatment. And yeah, also the heart ratio here, it's the heart weight against the body weight, is going down, which means the heart has not to work as much as when you look at the vehicle treatment. So this was the second story, and this is the team behind the second story. And this is not only I am, which are working on that. So this was really a work with multidisciplinary work. So we have guys from the neurology, from the cardiology, which is very important for the heart function, from the nuclear medicine, from the physiology, and also from the epidemiology. And this was a really great project, and hopefully the data were impressive for you. So yeah, I have to thank for your attention, and hopefully you have some questions which I can answer. Thank you very much.
Thank you so much, Michael, for sharing two very interesting pieces of your work. And you try really to condense it into those two stories. I would like to ask some few questions while waiting for other questions to come in. If we go back to the second story that you told us, this is the sick cell story.
Yeah.
If I understood properly, you told us that it is known that
people with heart failure will subsequently develop a stroke.
So I hope you can hear me. So thank you for sharing two interesting pieces of your work. And yeah, thank you for making it very condensed. But I'm sure there's several questions running in the mind of the people who were at Dr. Lee. I have myself some questions. So the first question is regarding the story. So if I understood properly, you told us that it is known from the literature that people who subsequently have the stroke usually have a heart failure before, a heart failure. But on the other hand, it's not known if somebody with a history of stroke would have a myocardial infarct or heart failure after.
Yeah.
So the first question is, are there some statistics that led you in that direction? So epidemiologic statistics from people who had a stroke before and then afterwards had a heart failure.
That's a nice question, and I can easily answer this because there's this is work in progress. So here at our clinic and also at our epidemiology, there's a big study parallel to our mouse study for patients with stroke, and they analyzed also the time period or some time period after stroke. In the patients they develop failure or some heart dysfunction.
Okay, and the other question related to that is that so in the clinical part of this study, you gave the patient Metoprolol, which is a drug that is used to handle heart failure.
Yeah,
actually. But did you actually saw some effect also at the brain level as a result from this treatment, or did you only look at the systolic, so at the head level, at the heart level?
Our focus was on the heart function in this case, but we also did some neurological functional testing of the mice, and what we observed, and this was also a little bit surprising for us, was that these mice with one functional test were over the time, so at week 8, so the end point of our study, were in the functional test as good. Mice with Metoprolol treatment were as good as mice which had only a short treatment. So, in comparison to the weekly treatment, they are really worse than weekly treatment. But with Metoprolol treatment, also a functional outcome, mice were better. So this was really surprising for us.
Great. So some people are moving forward with this piece of work, as you said, at the clinical level, if I understood properly. Yeah. If I go back to the experimental part, the first part of the work where you look at thrombo-inflammation, my question would be regarding GP6, GP1B, and GP2B and GP3A.
Yeah.
So you showed that targeting the platelet, but just specifically targeting GP6 will have some anti-inflammatory or anti-thrombotic effect, where the other will actually exacerbate the injury. So a very fundamental question is, what is really the difference between GP6 and the other categories of adherence molecules?
Oh, this is the mode of action. So GP1B is really important for the adhesion of platelets to the injured vessel wall, and GP6 is really important for the activation of platelets. And GP2B and 3A is also important for the interaction between, so for the thrombus growth and therefore also for homeostasis factors. And yeah, this might be a problem. So for the bleeding complications.
Okay. So Musab said, thank you so much for this wonderful talk. I have a not directly related question to your talk, but do you think that hypothermia has a role in preventing reperfusion injury after stroke?
Yeah, this is a good theme. So it could be that hypothermia is a good part, or it could be a good therapeutic strategy. I don't have exactly some data or some stuff in my head, but I know that some guys did this treatment or want to do this treatment to look at it if it's maybe a beneficial or plays a beneficial role in the case.
Thank you. Professor Amadi Iwunwo, who is actually the General Secretary of the Society of Neuroscientists of Africa, is asking a question. In the platelet study, is there no influence from the other blood cells in your platelet study? Because you talked mainly about macrophages. What are the other blood cells doing there?
In this story, I can say no, there is no important function at this case, but yes, you're right with this question. Also, neutrophils or macrophages are known that they play a role in ischemia reperfusion injury, but we do not look at this point of the study.
Great. So I didn't see any question in the chat, but I have questions. It's good that we keep the discussion going on. It's a very exciting study, and I also did a lot of work in stroke, so it's interesting also for my stroke. And my question is, you used a model, a mice model, which is the RAC1 mice model.
Yeah.
Those mice are depleted in T and B cells. And then you found a protection against ischemic stroke.
Yes.
And then the question is, if we think about the clinic or the clinical situation, well, those immune cells are important to protect our body. So how does it relate to what would happen in the clinic where people actually have their T cells and their B cells, or what would be a good strategy than targeting T cells, B cells, or how would it work actually if we were to transfer this to the clinic?
So what is known that targeting B cells, this is not so important, I think, but I think it's important maybe to also look at how we can target T cells. And I think the most important point about it is not to target T cells and then have the patient days without T cells or something like that. I think it's not the case. So what's really important is the time dependency. At which time point it's really good to target the T cells or platelets, and how long can we do that? So I think that's the important point we have to find out. So when is the best time point, and how long is the time period where this lacking of T cells or treatment of platelets has a beneficial effect, and when it skips a little bit in the other way around. So because the physiology of stroke treatment is really complicated or complex.
Great. So I would ask a very traditional question that we always ask in this webinar series, because we have participants from all over the world, and especially early career science like yourself. And if you were to give them an advice and a kind of motivation word about keeping going with science, what would you tell them?
I think the best thing is to have fun with that, what you have to do or what you want to do. So this is one of the most important points, because science is time dependent. There are much more fails than good things, or sometimes. But if there are good things, then they are really good, I think so. But you have you have to fight a little bit for yourself. So going through big data stuff, and it's an up and down a little bit, but hopefully you're confident enough that there are more ups and not so much downs.
Great, thank you for your answer. Thank you for the motivational talk. We have another question for Professor Amadi. And he said, in the heart brain study, which is the second study you presented us today, even though you concentrated on the transient MCA, do you expect a compensation from the cerebellum when it comes to motor coordination in this model?
That's a good question. It's hard to answer. It could be, because we also see when you look at the motor function or the function of the mice, so they're in the cage. I think 2 weeks after the surgery, I can't divide between a mouse of a control-treated mice, a sham mice, or if it's a TMCO-treated mice. So only with my eyes, I can't divide them into the groups. So this is maybe an important point of that.
So you would think that there's a component that's related to the cerebellum independently of the MCA per se, that the surgery does some damage already.
Yeah, this could be.
So, and how do you control for that then?
That's
when it comes to analysis, because you have to differentiate at some point between the treated and between the injured animal and your sham-operated animal.
Yeah, within the sham-operated animals, you see no infarct core, if I get the question right. So there's only, we let the filament in and then already out. So there's 1 second which there's no blood supply in the area. And so there is no infarct area. So there's, no functional injury in this mice, in the sham-operated mice. In comparison to the occluded treatment.
Okay, so I hope I got the question of Amadi right, and that your answer actually, that this ends the question. Then we'll get that. All right. Well, this is great. I don't see any further comments here in the section. I would say it was great having you here today. Thank you for taking the time to share this information. The webinar will be available for people to view. And I would say thank you, Dr. Bieber.
Yeah, I also thank you for the opportunity to talk here. That's really nice for me. So it's also my first time to do a webinar, so it was great.
So on behalf of our boss, so Amadi, who is the Secretary General of the Society of Neurosciences of Africa, we thank you. He extends his appreciation to you.
Thank you very much.